Hello and welcome to Workers' Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So, let's get started. Welcome to Season 3, Episode 17 of Workers' Comp Unwrapped. I'm your host, Anique.
And I'm Angela, and with 15 years in this industry, I've seen it all.
Today, we are talking about managing denied post-acute care claims, best practices. We're going to discover some strategies to appeal these denials using, effective documentation.
And we really need it. This is probably one of the most frustrating areas for everyone involved.
It really is. We've got a whole stack of resources here, regulations, case summaries, and they all point to this one chronic source of pain: denied post-acute care.
Oh, it's a total battlefield. I mean, you're basically going into combat armed with a fax machine and a prayer.
Right. So our mission today is to cut through all of that complexity.
Yeah, and find some clear, actionable strategies. Think of this as a shortcut, the ultimate shortcut to appealing these things.
Using documentation as the ultimate weapon. I like that.
Exactly.
Okay, so before we dive in, let's define our terms, just for clarity. When we say post-acute care, what are we actually talking about?
We're talking about that critical time right after a hospital discharge. So that could be a stay in a skilled nursing facility or SNF. It could be home health care, inpatient rehab.
Ongoing therapy, things like that.
Precisely. It's that bridge from hospital to recovery. And it's vital.
But it's also, it seems, a lightning rod for payers. They just seem to deny these claims constantly.
They do, and that doesn't just, create a financial mess for the provider. It can seriously interrupt the patient's recovery. It's a huge problem.
So if this care is so obviously necessary, why is the denial rate so ridiculously high? Is it just about cost cutting?
It's a mix, but a lot of it comes down to administrative gaps. Payers exploit missing pieces in the story you're telling them.
Okay.
So we're going to break this down into 3 parts. First, why the denials happen. Then, what documentation actually works. And finally, how to build a bulletproof appeal.
All right, let's unpack it. If the clinical need is there, the denial has to be coming from these specific exportable gaps. So what are the top 5 denial hotspots that insurers just love to hit?
It's fascinating because you can have a request that is 100% clinically sound, but if it's administratively weak, they will deny it. It's a guarantee.
So give us the top reason, number 1.
The first, and it is by far the most common, is the medical necessity gap.
Okay.
Your notes have to explicitly, and I mean rigidly, align with the state guidelines. For us, that's MTUS or ASUM. But just citing the rule isn't enough.
What's the missing piece?
The documentation has to detail the level of functional impairment. It's all about function.
Okay, so this is about more than just pain. You can't just write down pain is an 8 out of 10.
No, absolutely not. Because functional metrics like the patient can't transfer from the bed to a chair without help or can't walk more than 10 feet. Those are objective. They're measurable.
And defensible.
A pain score is subjective. A UR doc will just discount it immediately. If your notes don't speak the language of measurable impairment, you've already lost.
That is a key distinction.
Yeah.
Okay, what's failure point number 2?
Insufficient discharge planning. Hospitals are under a lot of pressure, and sometimes the discharge summaries are just vague.
Right.
The paperwork has to scream why the patient cannot safely go home. Without that specific justification, say, there are stairs and the patient can't use them, the payer will just default to the cheapest option. Every time.
And number 3 has to be about causality, right? This is workers' comp, after all.
You got it. Lack of continuity of care. The adjuster needs ironclad proof that this SNF stay or this therapy is directly because of the industrial injury. If there's a pre-existing condition, you better be able to separate what's new and what's old.
Okay, now let's talk about the administrative traps. The quicksand.
So that brings us to 2 big ones. Number 4 is just simple billing code errors. Post-acute care has some of the most complex codes out there. One little mistake on a CPT code or a daily rate, and you get an instant denial or a payment reduction.
And a payment reduction isn't the same as a medical necessity denial, is it? That's a different path.
It's a totally different nightmare, yes. A reduction kicks you into the statutory bill review or SBR or independent bill review, IBR, process. And this is crucial for everyone listening.
Okay.
UR and IMR are for medical necessity. Does the patient need this? SBR and IBR are only for the payment amount. Was it billed correctly? If you mix those 2 up, you're just wasting time.
That clarification is huge.
Okay.
What's the last trap?
Improper appeal filing. This is just tough. It's where providers shoot themselves in the foot. They miss a deadline, or, and I see this all the time, they appeal by sending the exact same paperwork that just got denied.
That can't work.
It never works. If the denial says you're missing a functional assessment, You have to send a functional assessment. You need new information.
So the big takeaway for you listening is that these denials, they're often about missing information, not a real fight over the patient's actual needs. It's an information game.
It is.
All right, so this is where we pivot. We know the 5 weaknesses. Now, what are the 5 golden pieces of documentation that turn that nope into a yes?
The key is to shift your thinking. You're not just documenting care, you're documenting justification.
Let's start with that functional piece again.
Number 1, a comprehensive functional status report. This has to go way beyond needs help walking. You need to quantify what the patient cannot do.
Give me specifics.
How far can they walk? Can they get out of bed alone? Can they manage their meds? If they have cognitive issues, you write that down. This objective data, it's the bedrock of the whole appeal.
It paints a clear picture. What about the hospital's part in this?
Piece number 2 is the discharge summary plus a specific clinical justification. Since the hospital summary might be generic, you have to add to it. You have to explicitly state the risks of sending this person home right now.
For example,
they just had new hardware put in their leg and they're on heavy opioids.
Yeah.
That requires 24-hour observation. You state that and you give a timeline for when you expect them to improve.
And the third piece, this goes right back to the payer's rulebook.
Absolutely non-negotiable. An MTUS-aligned treatment rationale. Don't just say they need therapy. You cite the MTUS chapter and section that says, this level of care is recommended for this injury.
Why is that so powerful?
Because it makes it easy for the adjuster to say yes. You're basically showing them that approving this is the low-risk, legally sound move for them. You're helping them do their job.
I love that, making their decision easy. What are the last 2 pieces?
Number 4 is a detailed plan of care. You have to show this isn't going to go on forever. So you specify frequency, 3 times a week, duration, 4 weeks, and measurable goals.
Like patient will be able to walk 50 feet in 2 weeks.
Exactly. It shows accountability. And finally, number 5, and this is crucial for SNF stays, the attending physician progress notes.
This is where you fight the skilled versus custodial care battle.
This is the whole battle right here. Skilled services are covered, custodial care is not. Custodial is just, help with bathing, dressing, things a non-medical person could do.
And skilled care. What makes it skilled?
Skilled care requires a licensed professional. Think complex wound care that needs an RN to assess it, IV medications, or a physical therapist who is actively changing the plan based on the patient's progress.
So the notes need to focus on assessment and management.
Yes. If your notes focus on assessment and management by a skilled professional, you justify the SNF. If they only say, patient needs help getting out of bed, you're going to get denied.
That one distinction, that's the whole ballgame.
It's the difference between getting paid and getting nothing.
Okay, we have the denial. We have our airtight documentation package ready. What's the 5-step game plan to actually overturn the decision?
Speed and structure. That's what matters. Whether it's a UR denial or a retro denial, you need to be proactive.
Step 1, get the enemy's playbook.
Exactly. Request the complete UR file. This is your right. Do not skip this step. The file tells you the exact reason you were denied. It's the UR physician's checklist.
So you're not guessing.
You're not guessing. Which brings you to step 2. Identify the gaps. You use their denial letter against them. They say you're missing an ADL assessment. Fine. That's the first thing you put in your appeal.
And step 3 is writing the actual appeal.
Yes. Write a strong appeal letter. And this can't be some little note. It has to be comprehensive. Clinical summary, MTUS references, functional limitations, safety concerns, and critically, you attach the new documentation that fills the gaps.
Okay, but what happens when they deny the appeal anyway?
That's step 4. Escalate to IMR independent medical review. This is often the final clinical battleground. IMR docs are focused purely on clinical necessity and guidelines.
So this is where that strong documentation package really shines.
This is where it pays off. When you can show the clinical need, the MTUS alignment, and the risk if care is denied, IMR overturns these denials all the time.
And the final step is the one that trips everyone up.
Track every deadline relentlessly. Deadlines are the real enemy here. Your case could be perfect, but if you're a day late, the denial stands.
So you have to know those dates.
You have to live by them. For UR appeals, it's 20 days. For IMR, it's 30 days. Miss them and you're done.
Okay, theory is one thing. Let's make this real. Walk us through a case where this strategy actually worked.
Sure. Had a case, a patient with a really complex left shoulder reconstruction. The hospital requested 14 days in a skilled nursing facility. You know, complex surgery, high pain needs.
And UR said no.
UR said no. They claimed home health was enough because the documentation didn't explicitly justify 247 skilled monitoring.
What was the problem with the initial notes?
They were too vague. They focused on pain and recovery. It wasn't speaking the language of functional necessity and safety risk.
So how did the provider flip the script for the appeal?
They made a tactical shift. They stopped talking about pain and started talking about objective function in the patient's environment. They submitted detailed OT and PT assessments showing the patient could not safely transfer or care for himself.
They quantified it.
Maximum assistance for all transfers. Then they added a home environment report. This was the game changer.
What did that show?
It showed the patient lived alone in a 2-story house with no railings and had pets. I mean, it was a massive fall risk. This proved that sending him home was a direct safety hazard. And then they tied it all up with a bow by citing the MTUS guideline for this exact surgery.
Wow. So they hit every single point we just talked about.
Every single one. The full package went to IMR and the denial was overturned. They approved all 14 days. The specificity, that was the key.
That really brings it all together. You're not powerless against these denials. You just need the right tools and, frankly, the persistence to map your documentation directly to what they denied you for.
That's it, to sum it up. Document function, not just pain. Reference MTUS. Include the safety risks. Appeal fast. And for goodness sakes, track your deadlines.
Post-acute care is so often necessary, but the system, it forces you to prove it in this very rigid, objective way. You have to speak their language.
You do. Documentation is the currency, and time is the ticking clock.
So, since time is the ultimate enemy here, let's leave everyone with a final thought. If we know that winning these appeals depends on having these 5 golden pieces of documentation from the start, consider this. How much time, how much money, how much frustration could be saved if the initial hospital discharge summary was written as if the case was already heading to appeal? What if it included all of that functional and safety risk data right from day one?
Building the appeal strategy into the initial discharge plan, now that would shift the power dynamic entirely.
Thanks for listening to Workers' Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patient's care.